Good morning. I'm Dr. Lisa Shubitz from the Valley Fever Center for Excellence at the University of Arizona, and I'm a veterinarian that does research on valley fever in dogs and mice to benefit dogs and people. And I'm going to talk this morning about valley fever of the central nervous system in dogs. We've talked in some previous lectures about what is valley fever, and then we talked about one where Kate and I gave a talk about mobility and ways that physical therapy can benefit dogs with valley fever. And today I'm going to focus on the central nervous system. And we're not going to focus on the rehab aspects of it, though I do make mention of it. I just want to talk to people about what it can do in the central nervous system of dogs. And some people here have some unfortunate experience with it. So we will get started. I made only one slide today to talk just very briefly about valley fever. It's a fungus, and it's a soil dweller, but it becomes inhaled and gets into the lungs of dogs or people or anything else that breathes air. All mammals appear to be able to become infected, and some of them get sick. Depends a little bit on species, immunologic status, some other things. The rodents that live in our little world in our desert are very important to maintenance of this pathogen in the dirt. It gets in the rodents, it lives on their hair, it lives on their feces and urine. Valley fever is a carnivore. I mean, it lives in us. It lives in the rodents, and in the environment, it lives in humid, somewhat cooler than surface temperature environments, and eats the proteinaceous waste that gets shed from the rodents, and it can also get into their lungs. But there's very little information about whether or not it makes them sick. But rodents don't live very long, and most of them die underground. So guess what they're doing? They're seeding the burrows that they live in with more valley fever. So, and I have a really cool story about my house about that, but I think I told it before, so we're not going to address it. So this is the life cycle, and on the left is the soil part. It lives as mycelia, so it's like an invisible bread mold growing in the dirt. And as it matures, it makes these little bitty arthroconidia, which are very tiny, and they can be inhaled very deeply into our respiratory systems, dogs or humans. And once that happens and it reaches our lungs, it almost immediately, within hours, starts to round up and make a spherule, which divides internally to make hundreds of endospores. And when those endospores get big, this thing ruptures and it releases all of these endospores, which can undergo this cycle of spherulation and expand the infection until we treat it with drugs or our immune systems control it, which is what happens for the majority of hosts that inhale the stray spore. So we're going to talk about one of the worst things it can do if it makes an animal sick. So 99% or more infections are acquired by inhaling it, but valley fever is very capable of getting out of the lungs, and it can go virtually anywhere. In dogs, the most common places it goes are the bones, the skin, the lymph nodes, and the brain. So we're going to talk about a lot about valley fever of the brain, but the spinal cord's connected to the brain, so the discussion of the brain extends all the way to the end of the tail. And we're going to talk about central nervous system valley fever. Okay, so we get some different presentations of this in dogs. And before we had advanced imaging like CT and MRI in particular, MRI has really changed the landscape of what we think valley fever does in dogs. With CT scans, we could very easily see big white lesions like this. This is a fungal granuloma. It means it made like a mass. And there's a lot of inflammation around the mass. This puts pressure in the brain. And the typical valley fever dog came in seizuring, or it had a few seizures and went to the vet, but often, like this dog showed up with cluster seizures at age 2 at an emergency hospital. And all this swelling causes them to seizure, and this is what we thought valley fever looked like in dogs, was seizures with granulomas. Now, interestingly, fungal granulomas in humans are not the most typical presentation. They get really excited and bring their brain granuloma cases to the valley fever meeting as one of the weirdest cases ever. It's like, really? You know, this is how dogs come in. So in humans, this is almost always a meningitis. And we'll talk about that. So, but for dog purposes, fungal granulomas are really common in the brain. They occur in the spinal cord, but they're rare. And honestly, I've seen more of them in cats than dogs. So, and they cause seizures, but other things they can cause, depending on where they end up, they can cause what we call some lateralizing lesions, and they can end up with circling, falling, because it's affecting one side more than the other side. They can come in with a head tilt and might be confused for old dog vestibular syndrome or some of the other peripheral type things. They can get loss of balance, and they can get altered behavior. And we're going to talk a little bit more about altered behavior when we talk about some of the other places that this goes in the brain that we've learned about, again, largely because we can image the soft tissues of the brain more accurately using an MRI. And I've worked in 2 hospitals now with an MRI, so we've gotten a lot of experience with this over the years. I say we because I just hang on the shirt tails of what the neurologists are learning because I work with them. So I want to talk a little bit about the anatomy of the brain. We looked at the picture of the middle of the brain and that had the granuloma in it, that image that I showed you on the last slide. This granuloma is in here, in this part of the brain. However, what I want to talk about is the meninges. And these are the thin, sensitive, very vascular tissues that surround the brain. They surround it on the skull side and they surround it on the brain side. And they line the ventricles, which are the sites in our head that contain fluid that moves things around, nutrition and things like that. It moves infections around too. And these can become inflamed or infected. And this creates seizures, but also some different kinds of lesions that we'll see. And the fluid can expand. And when humans get valley fever, they get what's called a basilar meningitis. So the meninges in this part of the brain where the little pointer is gets inflamed, and people develop very bad headaches, nausea, vomiting, dizziness, abnormal mentation. So it's very serious. It's very serious. And because these are swollen, the fluid cannot drain out of this. This undoubtedly occurs in dogs too. But we see so many granulomas that, again, this is a newer finding for valley fever that we've gotten because of MRI. So the disease in the CNS presents a little bit differently in dogs and in people, but in both species, it's very serious. And in humans, it's considered the most serious form of valley fever, most likely to cause death and requires lifetime treatment. So we call this inflammation of the brain encephalitis if we get a generalized inflammation of the brain tissue, myelitis if it includes the spinal cord, and meningomyelitis when we've got the meninges involved. So we're going to talk a little bit more about the encephalitis aspects. So for the encephalitis, we can get a generalized inflammation of the brain itself without granulomas, and that's where the inflammation is going throughout the brain tissue, but you don't have a specific big fat lesion with some inflammation around it like I showed you. And this was impossible to see with CT scan. So we call this generalized inflammation of the brain encephalitis. If we get inflammation of the meninges as well, it can be a meningoencephalitis. And this is what Dr. Alcott writes on a lot of his records. We've got inflammation of the brain, inflammation of the meninges also, and we're going to talk about a case that has both later. Or they may only have meningitis. They present a little bit differently, mainly with neck pain. They have a really bad headache, like people. Seizures. 50% of dogs, whether they've got a granuloma or they've got one of these encephalitic or meningitic kinds of infections, present with seizures. And the rest present with different kinds of symptoms that we've basically learned about because we've been able to more accurately diagnose this. We can see changes in behavior, changes in mentation. These dogs with encephalitis and meningoencephalitis often come in, they're really dull. There's a veterinary term for it if they're very, very dull. It's called obtundation, where they're just like almost comatose. And they can come in that way. And so it affects their alertness and their engagement. And many people come in and say this about their dogs, that even if they're not obtunded, they say, they're just not interested in anything. And it's more than lethargy. They report signs that the dog isn't all there. Mentally, it's not their dog. So, and then rarely, and I've heard of a few cases, mainly in the last year, new onset aggression. So sort of acute onset of aggression in a dog that previously wasn't may be a sign the dog needs to be evaluated for valley fever. So, and this is something that we didn't really know. So swelling of the spinal cord is called myelitis or meningomyelitis if it includes the meninges. Those meninges line the spinal cord, which also has fluid in it all the way down. It keeps it lubricated and nourished. And what we get, if this is in the spinal cord but not the brain, is we see weakness. And this can be in all four legs or just some legs. Paralysis, most commonly it occurs in the back legs, but it can occur in the forelegs. A wobbly gait, they're not really quite paralyzed, but they don't quite know what's going on. And this may be myelitis higher up towards the brain stem, which controls a lot of basic functions that we have, including some of the mobility. And owners will come in and report their dog just can't get up. And then the other thing, this has been covered in a previous lecture, but this is the valley fever has an impact on the central nervous system, mainly the spinal cord here, if they get infected in the bone. With the spinal cord, the bone swells. There's really no place for the spinal cord to go, so it gets crushed. And what happens is that the dog still can't walk. And it may be from a bony lesion instead of a lesion that's just inside of the spinal canal. So, and this is an example of one. I actually think this is a cat that I saw that couldn't walk. And he had 3 lesions along his backbone. But this should show you pretty clearly that the bone here is abnormal. You can see this bony proliferation on the bottom side. You can see loss of bone above. And this sort of whitish density in the middle of this bone is inflammation that's compressing the spinal cord, making this animal unable to walk. The other thing about bony compression of the spinal cord, so osteomyelitis, causing the neurological signs, is these dogs are very painful because the bone is infected and the bone infection is very painful. The spinal cord compression itself usually isn't painful, but the bone swelling is painful. So dogs with osteomyelitis are more likely to present with pain, as well as weakness and paralysis, as opposed to if it's just limited to inside of the central nervous system. And this is a little dog we'll talk more about because I got a couple story cases at the end for you. And this is an MRI, and it's not actually the best way to visualize bone, but this dog came in with behavior changes, emaciation, couldn't walk front and back, and that was a little hard to understand. So they looked in the brain first, but he actually has multiple bone lesions. This is in his thoracic spine. This is at the very base of his backbone. And these are compressing his spine very badly, and he was not able to walk. And we'll talk more about his specific clinical condition when we get through the rest of these slides. So diagnosis of central nervous system valley fever, history and clinical suspicion are really important. And here in Tucson or in Phoenix, it isn't very hard to take your dog to the vet for the kinds of clinical signs we've talked about and not have them think about valley fever as a very significant differential. Okay, even in an older dog, they're probably going to think of it. It could be something else. It could be cancer, but pretty much everybody's going to consider that valley fever is a possibility for most of these dogs, and you have to then try to differentiate that from the other things that could be occurring. And it's messy. It's messy. And this is why some of the diagnostics get expensive. So blood tests and titers can really help. If you've got a dog with these clinical signs and it's an 8-year-old boxer and his blood tests are completely normal, you probably might lean toward this is some kind of a brain cancer, because they have two kinds that are really common. But if he's got a 35,000 white blood cell count and a monocytosis and his titer is 1 to 128, valley fever is going to be a more very strongly considered for that dog. And he might have systemic valley fever and not in the brain, but probably not. So these tests can help the veterinarian try to narrow down how important they think that potential valley fever diagnosis is in the dog in front of them. And then x-rays, and I said the backbone is the main thing. That's the main place we have to look when we're suspicious they have valley fever and they come in with weakness, pain, and paralysis. We need to look at the backbone. When they have pain further up in the cervical spine, mostly these are dogs that have been adopted out of the animal shelter, but we see osteomyelitis of the skull. And these dogs usually don't have seizures, but they have pain. They have neck pain, they have head pain, they're really uncomfortable, they have loss of muscle mass over their head. And they look kind of neurologic, but they've got a really bad headache. And so x-rays of the skull could potentially be useful as well. And then to visualize brain lesions where you really need to try to sort out what's going on. Those are the kinds of cases that end up at the hospitals where I work, called tertiary care. And many dogs get diagnosed and successfully treated for valley fever without ever going through this. Some of them are just not doing well. They get referred and they get MRI or CT scans, depending on whether you maybe focus more on brain and spinal cord or you're focused on bone. CT is a better modality for looking at bone disease, and MRI is much better for the soft tissues of the brain and the spinal cord. So, and we differentiate this. These are the main things we have to differentiate this from: our epilepsy, tumors, other inflammatory diseases. This is not the only inflammatory disease of dogs that can cause these signs. And many of the others are actually treated with steroids. They're pure inflammatory diseases. They're immune-mediated inflammatory diseases. And if you give them just fluconazole, they won't get better. And then there are rare other infections, and they're not very common out here. If it's an infection, unfortunately, it's valley fever until proven otherwise, but we can get burned by not considering that it may be a different fungus that's actually less sensitive to at least some of the antifungal medications, or occasionally a bacteria. And the bacteria won't do well on steroids, and it is going to do well on an antifungal. And it's probably going to take a couple of rounds of diagnostics to get to that, because valley fever overshadows absolutely everything here. So we're going to talk about treatment, and I'm not going to talk specifically in depth about treatment. We're going to talk about the goals of treatment of valley fever in the nervous system, because there are 3 big things we have to do to treat this disease to help your dog feel better as soon as it can. So the first thing we have to do is kill the fungus. We use antifungal drugs to do that. And our antifungal drugs, as many people know if they've ever dealt with valley fever, don't kill it. They don't eradicate it, kill it. They do kill it, but they're not very good at eliminating it. So we left with a lot of residual, which leads us to long treatment times. But still, we're killing it. Between the drugs and our immune system, we're killing this. And these are our general approaches. The oral drugs are the most common. If they're not too severely sick, we can go with oral drugs and have very good responses to this. Fluconazole is overwhelmingly the #1 first choice of veterinarians to treat all valley fever, but even for central nervous system valley fever, it's really the drug of choice, including for humans, because this drug is extremely well known to develop good concentrations inside of the central nervous system, and many of the other drugs don't cross unless the tissues are inflamed, which allows us to use them to treat it. But fluconazole builds up great concentrations. If it's adequate, if the responses are adequate, this is a perfect drug to use. And then we have these others that I really don't want to delve into that much, but we would call them second-line drugs. We would reach for them if the dog's particular infection isn't very susceptible to valley fever. They're not getting better on it, okay? So, and they have their pluses and their minuses and their variable pharmacokinetics that we don't really want to delve into today. For dogs that we think they're going to die before our eyes or they're not responding to oral medication, we can use amphotericin B lipid complex drugs. We're down to only one of those. It's Ambizome, and it's about twice as expensive as the Abelset that I did all the work with and got people using this fairly routinely down here in the late 90s and early 2000s. But it's still, this will treat the brain disease. We've had very good responses to it. And it might save a life. And the typical protocol for the amphotericin B is about 12 to 15 treatments. But honestly, we have learned that, and this is, other people are doing this too in Asian countries where resources are a really huge problem for treating people. Even like 3 doses of this amphotericin B, which somebody might be able to afford 3, but if you tell them they need 15, they're going to put the dog to sleep. Will help to turn these around, because every single dog is going to need oral medication long-term no matter what. If we can treat them orally, it's great. If we need to boost it with some ampho, we do. It's an option. It's an option for people whose finances allow it. Either they've got insurance for their pet, that's the most common way they're afforded, or they've got enough reserve that they can do at least a few. And I've already said that they need long-term follow-up. So treatment for central nervous system valley fever is at least a year. Dr. Alcott and I argue about this. I have a very 30-year human medicine background, working with doctors where humans are not able to get over this disease. So I tend to go on the long side and look for low maintenance doses of medication that we can maintain dogs on. I'm a little bit afraid of taking them off it, though there are cases where they need to come off it for medical reasons, and we take them off it and keep our fingers crossed. Retreat them if you have to. So I don't think there's probably not one right way. I hate seeing it come back, and the owners do too. The second thing we need to do is shrink the swelling. I showed you that very large mass in that dog's brain on the 3rd slide that we showed. And that is taking up space in the brain where there's no space and causing seizures. We need to shrink the swelling. And the way we shrink the swelling, besides putting antifungals on it and starting to kill the fungus off, which reduces the stimulus for the inflammation, is we have to treat the inflammation more rapidly. And the normal way we do this is with steroids. And the hallmark drug is prednisone. If they need an injectable, they may receive a dexamethasone or triamcinolone. Dexamethasone is a short, very fast-acting drug, and I've seen it do magic on dogs. But when they have to go home on something, again, we're going to send them home on something, or we're going to use Pred. And how long they need it is highly dependent upon how severely they're affected, maybe what we're treating, and how rapidly they respond to this, our triad of treatment. We haven't gotten to the third one yet. So, but the first thing I usually try to wean back is the prednisone. The reason why is because if the fungus is being killed, they may not need this, and the steroids are actually harming the immune system, which we need to treat the fungus. But at the outset of this, the immune system's doing more damage to the dog than the dog can handle. So we've got to shrink the swelling, but the steroids, I call them a sledgehammer. I've worked with these in mouse studies to show what it does to a controlled infection in a mouse lung. And it literally takes apart the whole granuloma. And 90% of all of the immune cells die within 5 days. So this is why we get fast responses. But we need some of those immune cells to come back because the fungus is going, yahoo, I'm free. And they start growing like crazy. Now we've got an antifungal on them too. But so this is a balancing act with steroids. So we use them to shrink the swelling and try to figure out how rapidly we can reduce the doses to have less impact, all the way up to get them off no impact on the immune system so it can help with the valley fever infection. And then I think I already mentioned that the swelling doesn't have any place to go inside the skull or inside the spinal cord. These are very rigid spaces. And the compression, the other reason we need to shrink the swelling, the compression is damaging neurons, which have very limited capacity to recover. So when we damage neurons and cause problems, we're eliminating them, all right? We may not get them back. So this is why I feel that it's important early to try to get the swelling under control, to reduce the neuron death and allow optimal recovery of what hasn't been, killed or damaged already by what's been going on. So we may be looking at temporary neurologic loss of function versus permanent deficits that won't go away because we've had too much neuron loss. And this is why I think it's really important to use our two-edged steroids early and try to get the swelling under control and then taper it away quickly. So treating the swelling preserves and helps to recover the function. And then the third thing we want to do, I said that 50% of dogs with valley fever in the brain have seizures, is prevent seizures. Seizures also cause damage. And the kind of damage they cause is they lower the threshold for more seizures. So trying to control and prevent seizures is an appropriate part of this because we're going to get better outcomes with maybe no seizures down the road. And we use anti-epileptic medications for this. Now, as discussed, epilepsy is a differential for this. For one thing, the dogs that come in with valley fever heavily overlap in age range with dogs that have new onset of epilepsy. So it's a big deal to try to sort it out because the epileptic dog is going to have seizures every time you take the drug, the anti-epileptic medication away, and the fluconazole isn't really doing anything. And this is where an MRI might be able to help, MRI plus serology, to try to sort this out. Some dogs develop valley fever and they already have epilepsy, and usually they're already on their epilepsy medication. So we're not really looking so hard for valley fever in the brain or looking so hard at ways to treat it or control their seizures because they need their seizures controlled anyhow. The epileptic medications may need to remain for several months. And this, again, depends a little bit on the dog. A dog that had 1 or 2 seizures and went to the vet and got diagnosed with valley fever may not need these medications very long. The dog that shows up, in status epilepticus and spent 3 days in the hospital getting IV Valium while you loaded his phenobarb, that dog is probably going to be on the anti-seizure medication for a longer period of time, because nobody wants that dog to end up with that. And often they have a big mass, like the dog that you saw. It's going to take a while, even with putting steroids on it, to shrink that to the point where this dog is probably not going to seizure again. So reduce steroids first, reduce anti-epileptic drugs second. If their seizures come back, I usually just put them on their anti-epilepsy drugs, but we might also have to talk about adjusting their antifungal medications. And then the steroids obviously shrink the swelling and help to prevent more seizures. So some dogs can go on, like they've had one seizure. I have a patient like this. They had one seizure, they went to the vet, they got a diagnosis, they got on fluconazole right away. I think the dog had one more seizure. He was placed on Keppra. He's had no more seizures. He's had no steroids. He had a mild form, let's call it a mild form. It's never mild in the brain, in my opinion, but milder than some. And he hasn't needed any steroids. And we're starting to wean his Keppra. He's been 6 or 7 months without a seizure. I think he's going to do great. So, and if he doesn't, we'll put his Keppra back up. We might have to talk about choosing him a different drug at that point, a different antifungal drug. So shrink swelling. And so we're going to kill the fungus. We're going to reduce inflammation, shrink the swelling. And then, what was the other one I told you? Prevent the seizures. Okay. Some dogs don't have seizures. And some of these may actually need more supportive care. And these are little tiny boxes, and I'm sorry, but the people online can probably see them better than the people in the room. Hopefully you can see them, because if you're online, you can squint at your screen and see it. But we'll talk about supportive care. And actually, some of our non-seizure dogs with things like osteomyelitis and pain and paralysis and things like that may actually need more of the supportive care than some of the seizure dogs who, had 1 or 2 seizures, are taking some fluconazole and running around and being very happy. So for valley fever in general, good nutrition, monitoring adverse drug effects, and that includes the antifungal medications, the steroids, and the anti-epileptic medications, because these can all do things. Some dogs on anti-epileptic medications become severely depressed. They sleep all the time, or they're ataxic. And, we have more options in anti-seizure medication now too than we did 25 years ago when I started working with this. And we can maybe choose that dog a better drug that doesn't make it so wobbly on its feet to begin with. So we monitor all these things. And then liver enzymes, probably almost everybody in this room knows, are a big deal with our antifungal medications, and we monitor those. And the steroids contribute to the liver enzyme elevations. So being able to get rid of the steroids is great for dogs that have to take antifungal medication long term. It takes some drug pressure off the liver. And then if the dog requires phenobarb, in fact, to control the seizures, the phenobarb adds an additional layer of toxicity to the liver, and it competes with serum binding sites in the blood with the antifungal medication like fluconazole, actually any of them, but let's say most of these dogs are on fluconazole. So they vie for the sites on the blood proteins, which means that you might get an increased actual free level of the drug getting to the tissues of one drug versus the other. So now you have to measure your phenobarb levels and things like that. So the pharmacology is kind of complicated. So you can see why it's really important to keep working with your veterinarian to balance and adjust what needs to be adjusted, even just with the basic things, assuming everything's going well. And then for the seizures, monitor the seizure activity, obviously, that's easy. And we've talked about they could need an adjustment or a different drug for their seizure control medications, but if they're having a seizure once in a while, nothing may be changed. If they're having a seizure every week or they're having a bad seizure anytime, this probably needs to be addressed, and you need to call your veterinarian and let them know that things aren't going very well. And then pain control. These are the dogs with the backbone lesions for the most part, or maybe the skull osteomyelitis, or the ones with the meningitis is in the neck and they're really painful. These dogs need pain control. They need comfort. For one thing, it makes them grumpy. It makes them aggressive and unpredictable. And they're not mean. They're going, oh my God, I feel awful. Don't touch me. So pain control is really important. And many veterinarians are really good at getting balanced pain control now. And gabapentin's been a real game changer for things like neurologic pain. It can help these dogs a lot. Some dogs are really ataxic on gabapentin as well. But most of them, we can give them gabapentin plus something else to get this under control. And the steroids, because they shrink inflammation, help dramatically with pain. So, and then the dogs with vertebral osteomyelitis have neurodisability, but we're going to talk about that in this dot here. So dogs with a neurodisability, they can't walk, they can't get up and down, they can't get outside to pee or whatever. They just need some physical support. And this is harnesses and assistive devices. You can see them all around you in here, actually. And they usually only need these temporarily, but if you've got an 80-pound golden retriever that can't get their back end underneath them and they need to go outside and you need to help them, you need some kind of an assistive device to help this dog, because they're worth not giving up on. You just manage this for a little while, and the majority of these guys do really well. So again, usually short term as the dogs recover. And then also as they get more better, they're not so desperately sick from the valley fever, they can benefit from strengthening and mobility rehab for the weakness and paralysis. It can make them recover better. And actually, I work for a human infectious disease specialist who's done valley fever patients for 40 years, and he recommends physical therapy to nearly all of his patients. He says it helps them with the fatigue, it helps them recover from the fatigue. So this isn't even that novel. It's kind of probably should be more mainstream than it is. Okay, so now we're going to tell stories, and I only brought good stories. So this is the 3-year-old male neutered French bulldog that I showed you the MRI. He's got two vertebral lesions. I didn't see his brain MRI. He probably has stuff going on in his head, and he probably has meningitis on top of the actual crushing lesions that are making him not able to walk. But this animal was first seen by the neurologist at Tucson Veterinary Specialists. I got it later. They've gotten to the point now where they fix the acute things, and then I get to take care of it. It's okay. It's fine. It works great. This is the way it should happen. So this dog presented originally paralyzed in the hind limbs with a Schiff-Sherrington in the front, and that's because it's got a thoracic lesion and probably some meningitis in front of that. And what Schiff-Sherrington does is it causes stiff, rigid front leg. And the first day I saw this patient, it was on an emergency basis. He sat in the pen. He couldn't hardly move on his back end, but he sat in his cage all day long, staring at the top of his cage. What's going on with this dog? He just likes to stare at the top. Dr. Alcott says, no, he's got a Schiff-Sherrington. So it creates some rigidity up here, and they have a kind of a posture that they're pretty inflexible on their front legs, and their heads tend to go up in the air. And this one is obviously on its side, but I tried to get a picture showing you what they look like. They're kind of stiff. And this dog was also very skinny because he'd had valley fever for quite some time and wasn't doing well with it. He had tremendous loss of muscle mass along his whole backbone from his shoulder blades all the way to the bottoms of his back legs. He had huge loss of muscle mass. So this is somewhat consumptive, and also he's lost the nerve innervation to the muscles that keeps the cells big enough to, be a muscle. So he's multifactorial here. He did not respond to fluconazole. So when he came to Tucson veterinary specialists, they switched him to posaconazole, which is one of our super potent drugs. And that was, highly appropriate choice given the whole situation for this family. However, he's one of the very few dogs we have that had a very severe adverse reaction to posaconazole. And it was immediate. He developed vomiting diarrhea. He had so much vomiting diarrhea, he became dehydrated, and they couldn't get any of the other medication into him either. So he's not getting his steroids. So he's got this ongoing, can't treat the paralysis. And he came in on emergency to us on a Tuesday when I was there, luckily. And we treated his dehydration all day long, got him on some fluids, gave him a dexamethasone injection to try to shrink the swelling down, get him started in the right direction, gave him injectable drugs to treat the vomiting and the diarrhea. And I had him on no oral antifungal medication. It's like he needs a break. And we gave him a few doses of the IV amphotericin B, the ambisome. I think we gave him 3 infusions total. We gave him 2 that week and 1 on Monday the following week. And I had them start a different oral medication. We put him on voriconazole, which he is doing well on. And between the dexamethasone and the ambisome, the voriconazole is not going to work quite that fast. I had him start the vori on Saturday. We treated him on Tuesday, and by Saturday they could get the oral steroids into him and not have him throw it up. And he was taking the voriconazole. By Monday, the dog came in and his Schiff-Sherrington's gone. He's kind of trying to wag his tail, and he's wobbly, but he's walking. This dog wasn't walking when we saw him on Tuesday. And he hasn't been back in. Oh, here we go. Here are all the details. You can read them. So he came back in for a recheck at 2 weeks, and they said, well, he's trying to run and play in the backyard. And he's still, catching his toes in the dirt and things like that, but he was enormously better. And they could afford 3 amphos, but they couldn't afford 12 or 15. They couldn't even afford 6. And we got him on a drug he could tolerate. And we got his steroids where he could take them and not throw up. And he was doing well. Now, will his outcome be without any neurological deficits? I don't think so. I think he's going to have mild, proprioception, where he doesn't quite know where his feet are if you turn him upside down, or might catch a toe. I don't think he's going to heal 100%, but he's not dead. And he's walking, and he's doing dog things. So he did really well, but we had to be very, very aggressive when he came into us. And the records we got indicated that it was chronic, and I think they had tried to avoid, for financial reasons, seeking some level of tertiary care earlier on in his disease, because they were very concerned about the cost. But they managed to come up with what it took to get him straightened out and on the right track. And right now his treatment is probably stable and relatively not expensive for them compared to all of this. And he's having a good outcome. This is another one that also came in. I got this one recently, so some of this history that I want to talk to you about was what he presented with. This one's a she. Initially. And her initial symptoms that she was taken to her regular veterinarian for were pain and vocalized. So she's crying because she hurt. And this progressed over a few days to stumbling and blindness. And she went to the ophthalmologist, and I think maybe that's where the valley fever got diagnosed. They sent out a titer, probably because of what they saw in her eyes. And at her initial diagnosis, she also had a cough. There's no history that they took any lung x-rays. But this is probably an example of a dog where the dog inhaled the infection, maybe had some lung lesions, but this got out of the lungs so fast and into her brain. It's not always like it happened a long time later because nobody paid any attention to it. This one looks like it got out really quickly, and she developed the everything all at once. But then she came to TVS. I think her regular vet referred her. And on just steroids, the dog's vision had improved, and she wasn't stumbling as much, but they did an MRI on her. And what they saw, and they did also a cerebral spinal fluid tap, which was really very telling for this dog. And they, even with some steroids, but no antifungal medication, she had a very severely inflamed brain. So she had this meningoencephalitis. She had swelling of the brain itself, swelling of the meninges around it, and this went down into the meninges of the spinal cord. So she's got a meningoencephalomyelitis. Now, is that a mouthful? In other words, her CNS is on fire with this disease. And the cerebral spinal fluid tap had very high cells and very high protein, and it's bad. Your CSF is almost water. There's almost nothing in it. There's very little protein in it, and there's very few cells in it. She had a lot of cells. And Dr. Alcott sent it to a lab in Indiana, and they ran what's called an EIA on it, and they detected antibodies in her spinal fluid, and that's pretty diagnostic for valley fever. So that's this Mira Vista test for the valley fever antibodies. And this is a number that they generate from their test. I know it doesn't mean anything to you. So they put her on fluconazole, which is very logical, great. We've just talked about the fact this is a great place to start. And she hobbled along, but wasn't really getting better. And she redeveloped her weakness and stumbling and became unable to walk every time they tried to reduce the prednisone dose, which they were trying to do what they should do, shrink the swelling, get rid of this drug. She had a lot of steroid adverse effects. And she still has an alkaline phosphatase of, over 1,000 because of the drug. We're working on getting it down even more now. So at 3 months with this not very good improvement, can't get rid of the steroids, they repeated the cerebral spinal fluid tap. There's no reason to repeat the MRI. They know what's going on, and it's very expensive. But they repeated the CSF tap, and it still showed very severe inflammation. So even with steroids and fluconazole, this dog's disease is not responding to the drug. So we switched her, Dr. Alcott switched her to voriconazole and referred her to me. It usually takes some time to get in to see me. So she got on her voriconazole, got an appointment. And I think he maybe even saw her a couple of times for not doing great before I saw her. And I saw her initially in the middle of May. She was stumbling. Her legs were falling out from under her. The owner was really concerned about how she was getting along at home because she was having a hard time going anywhere. She was really kind of mentally dull. So she wasn't, a big complaint of the owner is this isn't my dog. She used to follow me all over the place. She just stares at the wall, or she just sits and, it has this vacant look in her eyes. So this is really affecting her brain. And this owner was able and more than willing to do some amphotericin B for her. So we gave her 6 treatments, and she was getting it 2 to 3 times a week. With that drug, it has to do with how much of the bottle we can use and not throw it away because it saves money. So that we have a little bit of a shifting schedule depending on what we have left. She didn't improve radically on the amphotericin B. The other thing that I did was, even though she had significant steroid side effects, I increased her steroids again. We needed to get this dog up and get her feeling better. So I put her back on a dose that she was on closer to when she was initially diagnosed. And she started to walk again. And the voriconazole didn't seem to have done any more for her than the fluconazole. She was on it for about 5 weeks before I saw her. So I switched her to posaconazole. And after the 6 amphos and 4 weeks of posaconazole, she was walking and she was looking around the world and friendly and engaged. And the owner was really pleased with all this. She was getting stronger and only falling a little bit. And this sort of physical disability was really concerning to the owner. And at recheck, I talked to Dr. Alcott about it, and keeping in mind that to me, the dog looked amazing compared to the last time I saw it. It's like, wow, she looks great. She's walking and she's not falling down and she knows where her feet are. She was just like, you know, when I saw her previously. So she has some residual gait deficits. And I talked to Dr. Alcott about it, and he says there could be loss of the most external tracts of the spinal cord, if you think of it like an onion, which is the way it's organized in terms of its jobs. And the least important ones are on the outside, proprioception and walking. Because the other more important ones are closer to the middle, the ones that will make you die right away. So she has a tendency to shuffle her hind feet. So she kind of walks like this, like a little old lady, you know, and will catch a toe once in a while. And her front legs come up a little bit more than would be completely normal, but she can see, and she's got a little bit of inflammation. So she's a little bit what we call dysmetric. She has a little trouble gauging what she needs to do in terms of how much to raise and move her front legs, and a little bit of a shuffling gait behind it. So this would be really common for the kind of disease she has. But she's also got a steroid cutback, and she's had no worsening of the neurological signs. So she's doing really well in that respect. And with neuro, you know, you can say, yeah, she may never recover, but it can take a year. I mean, I would like, if she's that way in a year, that's probably what she's going to be. But I would say she's got a year to show improvements in this. And that's at the end of a year, that's probably the dog you're going to have. But so she's doing really well. And for both of these dogs, I think their outcomes as pets is great. If you wanted a dog to do the Iditarod, you're in trouble. So in terms of mortality, we've talked about how severe this can be. We've also talked about some really horrible cases that are responding and doing well. And overall, dogs with central nervous system valley fever that get detected and get treated, so they survive and they recover. They recover at least where their quality of life is pretty good. They're happy with it and their owners are happy with it. There are some dogs with very severe disease that don't respond to treatment and they'll need to be euthanized. Some of these are dogs with refractory seizures. The encephalomyelitis can't be controlled. They just can't come back from it. It's too severe. But I'd say overall they're a minority. I think we resolve probably more than 90% of these. And I would guess that a lot of the ones that die, they die early. They come in, they're really, really sick, can't make any progress with it, and they die or get euthanized almost right away. The ones that we actually probably get to see in a practice setting where I am, I'd say that most of them have a pretty good chance. I will tell you that the little white poodle, I was afraid we were going to lose her. Even after all we had done, I was afraid we were going to lose her. So I am happy to take any questions. Yeah. Absolutely.
All right, we have one question about the new drug that they're talking about for humans for valley fever.
It is totally not available for dogs. There is no supply. and it's undergoing FDA approval, and we will not be able to get any of it.
Great, that's very nice. Okay. And then the next question, then we'll go to some folks out here. Are there pockets in Southern Arizona? Are there no locations that things are worse?
Yeah, you're living in one. Everything from Tucson to Phoenix, Pima County, Pinal County, and Maricopa County. And if anybody's interested in looking at human prevalence data, because that's what's available, they don't track this in dogs. You can look at cases per 100,000 on the Arizona Department of Health Services website, and they have it for years. You can look at different years, but if you want to look at where there's a lot of valley fever, that's a great place to look because it's the only data that we have. Are there little tiny pockets where it's in the dirt? Absolutely, but they're very difficult to try to understand exactly where they are. If you've brought your 5th dog into your house with valley fever, probably it's in your yard. And I have had 2 clients sell their house and move because that was their situation. So there are microcosms where the valley fever may be really dense in a specific location, but just generally speaking, Pima, Pinal, and Maricopa County rate is very high. The air conditioner is bringing spores into your house.
And then the last one, you want to address the elephant in the room, which is the vaccine. Do you have an update for us?
I have a tiny update for you, and that is that they've applied for emergency use authorization in zoo animals, and there are only 2 studies left that they need to produce for the USDA. So I think there's light at the end of the tunnel for licensing, but I don't know how long it's going to take because the USDA must be the slowest agency on the planet.
Okay, it takes some moving.
Yes.
What do you consider like a safe titer? My pit bull is 9. She's been on it for 4 years now. She was at 1.8. She's down to 1.2. But the vet I have to switch over says, oh no, she's on it 300 milligrams just once a day. He said that with his patients, when they get to 1.4, he discontinues it.
There is no safe titer. And the decision to remove a dog from valley fever medication is partly based on titers, but it also has a lot to do with how long has the dog been clinically in remission. Is there any evidence of active valley fever in the dog anywhere? Are you risk averse to having the valley fever come back versus possible adverse effects of long-term use of the drug? And some people don't want to deal with the monitoring and the anxiety of having the drug or the disease come back. They'd rather just use a low dose of the drug. And others are like, I really, really, really want my dog off this medication if they can live off of it. And then you do a monitoring program to look for early evidence of recurrence. And the farther out you are from stopping the drug, the less likely it is to recur. And unless there's something interesting about your dog and it's not resolved in some location, a dog with a titer of 1 to 2 is highly likely to, or 1 to 4 even, if it's been a long time, is highly likely not to recur. But I don't know the individual, I don't know the history of your dog. If he had 10 bones infected at the start, I would never take that dog off antifungal medication, no matter what his titer.
Because with our other dog, when we took her off, then we had to put her on the one for the anti-seizure,
The phenobarbital?
Yeah, because she suffered, she had 6 or 7 seizures, and we had to run her to the emergency room.
Yeah. So everything is a risk-benefit analysis, and it's usually a conversation with the vet so that you guys are on the same page in your decision-making regarding whether to continue the dog with antifungal. And the history and the ancillary diagnostics for that dog weigh into that decision-making process.
Is there some type of sensitivity test for valley fever that would indicate which antifungal to use, or do you just simply start with fluconazole and go up the chain until something sticks for a particular dog? Because there are sensitivity tests for bacterium And so I just wasn't sure. if there was
So
something
do you know what you have to do to run a sensitivity test?
I do, that's why I was
Okay.
asking. I assume there's not.
Do you know how often we get a fungal culture from a dog with valley fever? Almost never.
Okay.
So
I just
the
wasn't-
problem, the answer to your question, and it's a very good question, is yes, we can do fungal susceptibility testing. And Dr. Wiederhold at the University of Texas, San Antonio, which is where I send my drug levels, and we've done work together, has a collection of 530 human clinical isolates. And they literally took them all out of the freezer and did MICs on the whole lot of them. And 30% of those are not sensitive to fluconazole. So because we so seldom get a culture on a dog, and we have to do, a human will cough on a plate for you if you tell them to cough. And you can send that to the clinical lab, and they can grow something off it, and they can do a culture, they can do a sensitivity test on it. A dog is not going to cough on a plate for us. And I haven't had one owner yet that wants me to anesthetize their dog and do a BAL and grow it so that I can find out whether it's sensitive to fluconazole. So from a practical standpoint, we empirically start with a common drug. Now, I'm not saying that fluconazole is the right drug, because literally no one's done that research. This is practice in Arizona, and we are almost finished with our online WOOF study. We enrolled almost 400 dogs, and the last one is going to finish, I don't know, around the end of the year, and then that data will come out. What veterinarians use to treat fluconazole, and over 90% of these cases are in Arizona, and it turns out over 90% of dog cases are in Arizona. So I was like, well, why can't we get cases from other states? Well, it's because they're here. So when you asked me, online person, are there hotspots for valley fever? We are living in the hotspot for valley fever. This is where it occurs, is Arizona. 90% of the cases in dogs are in Arizona. Actually, it's more like 92. And this is published. So anyway, so veterinarians in Arizona use fluconazole. They use it out of the 400 dogs, less than 10% were started on a different antifungal medication. And itraconazole was the other one that most people use. The other ones they're more expensive, and they're more salvage drugs. I think they need more monitoring. But so you know, fungal sensitivity testing would be great. And if this was a human world and everybody had health insurance, you know, maybe we could do it. But some people might still decline this because the procedures for getting a sample that we can grow are still invasive. Whether you have medical insurance or not, most people don't want to anesthetize their dog, stick some fluid down its lungs on the chance that you might grow a spore out of it and be able to do this test. They're not into this. Can you just give my dog some fluconazole? So that's the long answer to that you probably didn't need. I think there are multiple questions still. Yeah, okay. Let's see. We'll start with you, then we'll do Naomi, and then we'll come here.
When you're talking geographical areas and you're talking hotspots, does it matter, say, the east, southeast sides of Tucson can be wetter, they get more monsoon rains compared to the northwest areas that's a lot drier, Marana's areas, stuff like that's typically drier. Is there any correlation with?
I made a map while my dog was dying of lymphoma in 1998, 97. And somebody else has done one since with humans, and the cases are more in the foothills than in the city. This probably has a lot to do with landscape cover as opposed to where it can live, okay? And we've dug up our cities and covered them with blacktop and grow grass in the yards, especially the older parts of town. And the foothills areas are where the cases concentrate. And we mapped the dogs on top of the humans back then, and that's what we saw. And I still think that that's probably characteristic of what is going on. And then there was a second part to your question.
No, I was just saying, the east, southeast, or wetter areas of town compared to the
No.
northwest, north, as far as rain. Does that have anything?
It's
to
the
do with it?
foothills. It's the foothills areas, and I don't know that anybody gets enough rain now to make any rain correlations with it. Actually, less rain seems to make more valley fever. All it's done is go up and up and up. We used to get kind of a break with monsoons, and now it's just like constant. All year. There's still some seasonal peaks. One is in the like April, May, June, and the other one is like October, November, December, which those are post rain. We have two rain seasons in Arizona theoretically, but there are some years where we don't get rain. For the last 18 months we've had almost no winter rain. There's just endless valley fever. So let's see. Naomi had a question.
If you could just talk for a minute about the difference between fluconazole and fluconazole.
Yeah, I can. So fluconazole is, they're all in the same class, obviously. They end in azole, but the chemistry of some of these drugs is it varies a bit. Fluconazole is a water-soluble drug that is very little metabolized by the liver compared to all of the other antifungal medications that we have, or all the other azoles. And so this is one of the reasons why veterinarians use it, is it's user-friendly. If you give it to the dog, it probably gets absorbed, and there's a lower risk of liver adverse effects than there are with the other drugs. Itraconazole is extremely insoluble. It's hard to use. You have to use the commercial forms because the compounded powdered stuff is just goes in one end and out the other and bypasses the whole dog. So, but it's more potent. Fluconazole is the wimpiest drug we have. It's amazing it works, and it does work. It does work, but it has higher mean inhibitory concentrations than all of the other drugs we have. Itraconazole, voriconazole, and posaconazole all range between 1 and 0.5 micrograms per mil, so they're very good. And amphotericin is in that range too. It's 0.5 to 1, depending on the individual cocky strains you tested against. So they're more potent. It's the chemistry and the tolerance that may affect how an individual patient responds to a drug. And posaconazole is a drug I really like. And it's not supposed to be very absorbable, but the tablet formulation that they sell is really well absorbed by dogs. It's really potent. I don't see tons of adverse effects to it, though I did show you a case that had a terrible adverse effect. The more you use something, you'll find the adverse effects. That's all there is to it. Nothing is perfect. So, but itraconazole is less water soluble, more potent, and it's great for bone disease. So there are some differences in that. Fluconazole is really good. It penetrates the eye. It penetrates the central nervous system. And it's great. It gets widely distributed in all the body tissues and crosses the blood-brain barrier. So it's a really good drug. Voriconazole crosses the blood-brain barrier. And these two drugs are actually good for eyes and brain. Though, again, with the swelling, the posaconazole and the itraconazole can get there. And we have several CNS cases being treated with posaconazole with great success, even though in theory it shouldn't get there. So, okay, we had 2 questions over here, I think.
I have 2 questions. You talked earlier that dogs were having extreme headaches.
Yeah.
What are the symptoms?
Neck pain usually, grumpiness, hold their head low. They don't want to be touched. They don't want to be touched. Yeah, ICT Journey's skull too. The dog, my own dog, and he doesn't have belly fever, but he's got pain I can't pinpoint. But I even looked at his head, like, does he have something going on there? But so they don't. They're very sensitive to pain, and these are again usually the meningitis dogs, or they've got inflammation in the base of the brain, neck, in the meninges. They're very painful, and they don't want to be touched, or they may try to bite. You know, a dog that normally is fine if you touch them or move them, they may scream or bite. The little Bonnie was crying and crying. I mean, that's why her owner took her to the vet, because she was crying with pain, and she had that severe inflammation in her brain and in the upper part of the spinal cord. And the other question you had?
The other question is, we were talking about controlling the pain, and most of us use gabapentin, but there was still
Carprofen,
use gabapentin plus something else.
steroids. Steroids shrink the swelling, so they reduce the pain because they're reducing the pressure. And amantadine can be used. It's part of a multimodal pain program. Tramadol they don't use very much anymore. The scoop on tramadol is that almost all of it's removed by your liver if you take it orally. A fentanyl patch could work because it bypasses the liver. But again, that's a very short-term solution. And carprofen, anti-inflammatories, but they can't take steroids and anti-inflammatories. So if they're on steroids, drugs like carprofen cannot be used. So your steroids, gabapentin, and amantadine are probably going to be your main pain thing. Anything I'm missing, Sally? Yeah. So, okay. And then you had a question.
This might be too generalized, but is there a way to know by titer level or other measurement where a dog is kind of getting more symptoms versus sort of stable? We've had a dog who sort of stalled at like 16.
No. No. That's like a whole nother lecture.
Yeah. And this is our first time. So I appreciate that.
Titers are very difficult to interpret. And we are in the process of completing a manuscript that's going to go out showing that the laboratory variation is extreme. And I just think they're really hard to interpret. The longer I do this, the more I think they're very hard to interpret. Again, that's like a whole nother talk.
Sorry.
Okay, that's okay. It's not a general question. It's a very complicated question. And there are very few data to actually answer that in an evidence-based way. Okay, other than dogs with really low titers that have come down and are clinically stable are probably okay. But I mean, we have dogs that never have a titer greater than 1 to 2 or 1 to 4, and they're dying. And we know it's valley fever. So they're really difficult to use quantitatively to make general conclusions about the disease. Okay.
Go back to the fungal. My dog, after about a month, did not tolerate it. Vomiting, diarrhea, the whole were pretty bad. We did take her off at the night, and now she's doing fine. She's stable. But if that's the least toxic, it's really impacting the liver. If that's the least toxic of the antifungals, what are our alternatives?
So I'm glad you asked that question, because even though fluconazole pharmacologically is the least likely to affect the liver, I see a lot of idiosyncratic reactions to it where dogs' livers are not tolerating it at all. And of all the drugs I use, honestly, fluconazole is the one that's most likely to cause vomiting, diarrhea, and GI signs. Also, a bad reaction to fluconazole does not actually predict, not even the liver, a bad reaction to one of the other 3 drugs. So I always try a different drug, unless the dog doesn't need the medication. I give dogs drug vacations. Let's take it away. If I don't think the dog is going to die, yeah, sure.
And she wasn't showing any typical valley fever symptoms, which took us a while to figure out.
Okay,
So I'm just concerned.
sure.
Still has the spores.
Well, they may need to do as I mentioned in one of the other questions, you may need other diagnostics to figure that out besides the titer. The titers are really super muddy. So, and no, but we have a very high population of asymptomatic dogs. Asymptomatic. They're positive, but they're actually not sick with valley fever. So that just adds to the clear as mud problems with titers. Okay. So, you know, if she's got lung x-ray evidence of valley fever, that could be important. You know, if she doesn't have any evidence of valley fever, maybe it was something else. And, oh, by the way, you discovered a titer she's had for 3 years. Yeah. Yeah. When my current whippet came up positive, he was actually sick, but he had a GI thing. And I couldn't make it better, so I took him to my vet, my local regular vet. So fix it. And he popped up with a 1 to 4, and she's like, well, do you want to treat him? It's like, no. And I took him to TVS and took a chest x-ray. It was clean. None of the rest of his blood work is indicative of valley fever. And he's had a 1 to 4 titer since he was 3. Oh, it's now 1 to 2 now. It doesn't go away. He's never been treated. So you had a question.
I have 2 questions.
Okay.
Number 1, can an individual bring their dog directly to you, or are you strictly on like referral from a veterinarian or a specialist?
Well, Ashley will tell you you need a referral. She'll tell you she wants a referral. But you can call and negotiate that with her at Tucson Veterinary Specialist. And I'll warn you that it takes like 3 months to get in. So
What are the variables that determine whether or not the valley fever is going to escape the lungs and go to the brain?
man, we would win the Nobel Prize if we knew that. No, absolutely not. This is biology that probably occurs within the first week or 2 after the patient is infected. There's a ton of research going on right now on what happens, what the cells do when it first encounters the spore that you breathe in. All right, and most people, we're not doing this in our lab, we're working on granulomas, but they want to know what happens and does it shift the immune response one way or the other. So it could be like the day you inhaled the spore, your genetics, what else you inhaled it with, you know, do you have some other underlying infection, whether your T cells were asleep that day or not. I mean, it's really complicated. And my guess is no one's ever going to figure out there's like one single thing that happened. I think it's really complex. The microbiome affects it. I mean, this is all stuff I used to like, nah, you guys are lying. And it's true. It's true. The research is just emerging. And the reason why it's taken this research so long is because the sequencing of multi-organism genomes, they call it multi-omics, and the computing capacity to sort out all the A's and T's and G's and C's and make this into information that people understand has taken this long. And this field is expanding by leaps and bounds, and that's why we have nasty data centers that heat our world. But I mean, I don't think this is going to go away because this kind of supercomputing makes learning these kinds of things possible. It's really kind of fascinating, actually, once I was able to wrap my head around the fact that this might have an influence on something. It's kind of cool. It's like, wow, so what you eat might change whether or not how good your immune system is. I was like, wow, that's something we can control, sort of. So that was kind of an interesting question to have to answer because it's so multi-layered. But the simple answer is we will never have a test that will tell you whether the spore your dog inhaled is going to cause a disseminated infection or he's going to never cough and become immune.
AWOL set, will it ever be available again? We used it at PAC with a lot of success.
I don't think it will. I called the company every 6 months for 2 years. Like, yeah, maybe. Yeah, maybe.
A few of us have called too, and
I mean, it's been, I think we're pushing 5 years since it went off the market. My
dog
guess
was the
is
last that PAC had, and that was over 4 years ago.
They don't have a big enough market to retool their plant. That's what I'm guessing is that's a sterile fill. And they have to be certified by the FDA. And when your equipment ages, it all has to be recertified and redone. And they probably did the math and went, we're not selling enough of this to retool this plant. They haven't told me that, but this is something I kind of know about, that I've learned about other drugs. So that is, I suspect we're stuck with Ambizone, which was more widely used among humans than Abelset anyway, but it found a real niche for treating invasive fungal infections in dogs. It was a fabulous drug for us. So ask Kate. That is correct. That is correct. That is a very quick question.
Okay. Thank you very much, Dr.
You're welcome.
One thing I want to mention, there are little stand-up lucite stands outside. One has a QR code for donations to the Valley Fever Center for Excellence. Please look at that one. There's also another one that has a QR code for donation opportunities for the Aloha Companion Foundation. Your donations to either organization keep both of them going. So we appreciate you and thank you for spending your Sunday morning with us.
Thank you.
Email. Because we brought
She was disseminated about like she was the last on Abelset at PAC. Right side, her front paw when she's walking.